So he's cracking the code and opening the doors for all of us to contribute in the development of these vaccines. So perhaps that's why he's qualifying to come to the Africa and the world, because he's going to get us into that door. Dr. Ale Olotu, on the other hand, is a senior research scientist and director of science at Ifakara Health Institute. And if some of you know Ifakara Institute in Bagamoyo in Dar es Salaam, it's one of the leading institutes on the continent, together with KEMRI and the others. There's, I think, one in West Africa that is really doing some good work. And so being the director of science at an institute like that places Ali in a very significant league. And he's also associated with KEMRI Wellcome Trust Research Program. And over the past 14 years, he has significantly contributed to the understanding of malaria epidemiology and naturally acquired immunity. And both of them have combined to do very good work in cracking the code. So on that note, I would like to invite both of them to begin to crack the code. Thank you. I'm very eager to leave the stage so that the two can then take us through. So please welcome. Thank you.
Thank you. Thank you very much. Good morning, everyone. Good morning. Good morning. That's more like it. Thank you very much. So first of all, I would like to take this opportunity to thank Dele and the organizing committee for inviting us to this incredible gathering of minds. It has been my first time in this event, and I must really admit, it has been really an exciting 2 days, and I'm looking forward to learn more and engage with as many people as possible. For me, it has given this sort of intellectual humility to say that you meet people working in other different aspects, different fields, and it makes you understand that, recognize that, the world is bigger than you think it is. So I think it's really an amazing experience to be here and to engage with all of you. So we have been given, we've been asked to talk about cracking the Malaria Code on defeating an old enemy. And the title itself, Cracking the Malaria Code, implies that we are all engaged in solving a very complex and difficult problem. And indeed, malaria, as you know, is a very complex disease. And having worked on malaria for the last 17 years really has given me a very deep understanding and a humility to really know that malaria is not an easy problem to solve. It is a disease that involves an interplay of different dimensions. So we are talking about not only biologic, but also social, economic, ecological dimensions, and therefore solving the problem of malaria requires a very comprehensive strategy that really looks into all these aspects. So although I have been working only on certain aspects of malaria, we have all to recognize how complex the problem is. Now, talking about defeating an old enemy, again, malaria has been with us for many, many years. It goes back all the way to 30 million years. Other records may show even more than that. So therefore, the parasite itself has learned to sort of evolve with us over all these many years, and therefore finding solution to this kind of a problem always gives us a challenge. There's always challenges associated with that. So I want to share with you this really sobering statistics. And for a moment, just imagine every single minute that we spend here, a child would have died of malaria. So by the time we finish this talk, which is about 90 minutes, 90 children in Africa would have died of malaria. And these are not just statistics. This is a reality. And for me, having worked in rural areas of Africa, specifically in Tanzania, I have witnessed that firsthand. So I think it's very important when we look at the statistics. It's very easy to look at the number and say, oh, that's a huge problem. But you have to go there. And behind these statistics are people, lives, and families suffering. So it's really something that you feel it when you work with people in the field. So for me, it has been a passion to work on these diseases because I have experienced it firsthand, its impact in the community. So last year, there were an estimated of the estimates were around 250 million cases of malaria, and this is an increase of 5 million cases more compared to the numbers before that in 2021. And Africa accounted for about 94% of those cases. So we bear the largest burden of malaria. And there were about 600,000 malaria deaths in 2022. And if you look at the statistics again, they show us for the past 5 years, the percentages of malaria death that occurs in children hasn't changed. And the majority of death we see for malaria, of course, it is in children under the ages of 5. So these are the most vulnerable population in our communities. And the other vulnerable population are pregnant women. And last year, there were 13 million malaria cases in pregnancy, and this is 40% of all the pregnancies in Africa. And I want to say that these are usually the estimates, and probably they are underestimates, because given our health system, probably we're not accounting for all the cases that make up to WHO databases. So again, it's important to understand that malaria is a serious disease. So this is just a graph showing what other events in the community can have in terms of impact on the malaria number. So if you look at the number of cases on your, I should say, left graph there, between 2019 and 2020, there were a jump of number of malaria cases, and this is also reflected in the number of malaria cases. So both deaths and cases jumped up in that year. And this is a reflection of what we all experienced in the globe, and that was the sort of COVID pandemic that really disrupted some of these interventions that were being rolled out. And if you look at the number of malaria cases between 2021 and 2022, there are very few countries that contributed to those number of cases. And if you look at those cases, majority of them is Africa. So Africa, again, we bear the largest brunt to these diseases. So then I wanted to quickly go over some of the terms which you will be hearing us using in our discussions today. And there are 3 terms here. The first one is malaria control, malaria elimination, and malaria eradication. So when you talk about malaria control, this is really like coming to terms with malaria and reflecting only on managing it rather than completely sort of removing the disease from the community. And therefore, we work towards sort of managing transmission, reducing the severity of the diseases, managing the death, but really you have to continuously intervene so that the situation is manageable. But I don't think this is something sustainable over a long period of time because it requires a significant amount of investment, and the community continue to suffer if you're just focusing on control. And then we have elimination, and this is an interruption of the malaria transmission in a sort of geographically delineated sort of space or country, we could say. And here what we are aiming is sort of reducing malaria transmission to zero, so there are no new cases in a given country. And you still need to continue intervening so that you stop the reestablishment of malaria in the country. And the third term is eradication. Here we're talking about sort of a global removal of the disease. So it's the permanent reduction of malaria to zero worldwide. And if you can be able to achieve this, then it means there will be no longer requirements to sort of intervene in subsequent years. So most countries, of course, are now in the control elimination mode, and the eradication, obviously, is really a more challenging goal to achieve, but nevertheless, all of us have to have that aspiration to get rid of malaria in the long term. So have we tried to eradicate malaria before? The answer is yes. So in 1955, the Global Malaria Elimination Program was set to interrupt malaria. But although there was a limited success, it failed significantly, especially, again, in Africa. And if you look at the countries that were able to eliminate malaria, most of them, 27 out of 37 countries, were all in Europe, in America, and Africa actually performed very poorly, and this was abandoned in 1969. So there were a lot of lessons to be learned from there. Of course, we didn't have very good tools. It was more challenging to do this in Africa, but I think it sort of taught us that it requires more efforts, more financial resources, and more coordinated approach, and more comprehensive approach, really, to tackle malaria in Africa. So these are some of the countries that have been certified as to be free of malaria. And as you can see, majority of these countries are outside Africa. In Africa, of course, we have Algeria. And just last year, Cape Verde became the 43rd country to be certified as malaria-free. So we have a lot of work to do in Africa, where I say more than 90% of malaria resides. So in 2015, the world came together and formulated what we call Global Technical Strategy for Malaria. And this was sets of guidelines or a plan to really help the country towards malaria control and eventually elimination. So all countries are encouraged to think about eliminating malaria. And as more countries eliminate malaria, then the goal of eradicating malaria will become a reality. But at the moment, we have to recognize it's very difficult to talk about eradicating malaria. So most countries are focusing on eliminating in the sort of longer term. And the strategy itself set a target of reducing the global burden of malaria by more than 90%, as well as mortality for more than 90%, and help as many countries as possible to actually achieve elimination. So that's the overall goal. And it has 3 pillars. The first pillar is ensuring that we have access to all the proven available interventions that target sort of case management or treating of malaria, diagnosing and treating of malaria, as well as preventing malaria transmission as well. And then the second pillar talks about ensuring that these countries focus on elimination. As I said, control is not a sustainable thing, really. Therefore, most countries have to really set their goals toward elimination. And every country has a different spectrum. If you look at the spectrum between control and eradication, each country is at the different stages, depending on the burden of malaria, the ecology, and other factors. But each country has at least to set its goal in the long term towards elimination, because that is the only way forward to get rid of malaria globally. And the third pillar is using surveillance as one of the core interventions. And this is important because, as I said, surveillance helps you to understand, the situation of malaria, and also helps you planning. So you use it as a strategy to properly plan and therefore tackle malaria more efficiently. And this is supported by two elements, and this is harnessing innovation and expanding research, because the research is always an important aspect of all of this, because it gives you new tools to fight the malaria. And the second element is strengthening the enabling environment. And these are all the environment, as I said, because malaria is not only about the parasite itself. There's so many other things that needs to be done right in order to eliminate malaria. And I will go through some of these few areas, sort of points. So case management, as I said, we all know now we have diagnostics that are able to diagnose malaria. We have microscopy, but we also have rapid tests that can be done, at the bedside, and you can actually know about the malaria very early at the point of care. And we have, of course, good treatments, medicines available at the moment that are able to treat malaria, as well as prevent malaria, of course. But important is to also continue to look at the, how these drugs are working and monitor them very carefully, because then you are able to identify any signs of resistance and therefore make sure that you act promptly to prevent the negative outcomes that can come out of that. Another aspect, apart from case management, is actually prevention. And therefore, we have different tools. We have vector control tools that prevent transmission between the mosquito and humans, but we also have preventive chemotherapies, and these are given in different population or at-risk population. So I talked about children, and I talk about pregnant women. So we do have drugs that can be used in this population to prevent them from getting malaria. One of the very important and tool that has been used is called SMC, or seasonal malaria chemo prevention, and this has been instrumental in reducing the burden and death of malaria, especially in countries where malaria transmission occurs in a very particular time of the year. And it is between 3 to 4 months, but it's very intense and can cause severe damage to the community in terms of mortality or deaths. And mostly this happens to the north of Africa and in the Sahel region. And this medicine is given during the period just before the transmission season, and that can really help to save millions of lives. The other way you can also treat children is using now so-called perennial malaria chemoprevention, and this can be done in other parts of Africa where malaria occurs throughout the year. Malaria transmission occurs throughout the year with very sort of short peaks reflecting the rainy seasons. But again, all these are sort of available tools in our armament that we can use. And again, in pregnancy, pregnant women are given these tools as well.
My brother Ali,
yes.
I love your presentation.
Yeah.
I'm just very mindful of the time. I think if we could get to the remaining highlights very quickly so I can bring Adrian on. I think the room really wants to engage you in your exciting work and the fact that we're on the cusp of really beating this stuff. So
thank you very much, Adele. That's appreciated. Yes. Yes. So very quickly, because we want to get to the discussion part. So all these tools, as you can see, have had a significant impact in terms of really helping us with malaria. So this is what the most important point I want to make. And this graph just demonstrates bed nets, ACT, these are artemisinin combination therapy, and the indoor residual spraying as one of the important tools we have. We must also recognize the progress. This is very important, so we've made a significant progress using these tools. We have almost half the deaths, but also we have reduced by more than 30% the burden for malaria globally. But there are some challenges. So we have challenges with anti-malarial drug resistance. These are starting to come up, especially in Africa, and this is very worrisome because we have very limited medicines to treat. But also we have resistance to insecticides. These are insecticides, these are the ones chemicals use in our bed nets to prevent mosquitoes from biting us. So with the resistance, it means we are no longer protected. So again, this is a big challenge. So that's why working on research is important, and these are all sort of new tools which are available, vector control, diagnostic, and malaria vaccines. So briefly on malaria vaccine, I want to say, to give a personal history, I became involved in malaria research, partly because immediately after my graduation and spending about 2 years training, I thought that to make more impact, I must go to research, and therefore do more research work to have, so that my work can have a significant impact. And malaria by then was still the leading cause of admission and death in Tanzania. So having an opportunity to go and work with one of the very renowned research institution in Kenya was for me really a life-changing experience. And my first work on malaria vaccine was on RTSS. So this is the first malaria vaccine to be recommended by WHO. And I worked with this vaccine in Kenya and Tanzania in early 2011, 2012, and demonstrated that the vaccine had the potential to prevent malaria in children, but there was a very complex interaction between the way the vaccine works and the malaria exposure. So in areas where the exposure was very high, only 3 doses of malaria were not enough vaccines. So you will get a very good protection in early, for sort of 1 or 2 years, but then there will be a rebound of malaria in those kids who were vaccinated. And this was an important work because then it informed the subsequent work about malaria vaccine, and you will hear it from Adrian Hill. So then the phase 3 was done, and I was part of that. Again, very much privileged to be part of that work, which led into RTSS being recommended by WHO. And of course, in showing that RTSS can work even better when it is combined with other tools that are available. And then came the R21, again, very much involved with this. This was the vaccine that earlier study in West Africa was very, very promising, and we are now part of the 4 countries across Africa working on this vaccine, conducting sort of a long-term follow-up. But last year, it was recommended by WHO based on the results in the first year of follow-up. And these are the graphs that you can find it in the paper, showing very high efficacy of about 75% against clinical malaria, and very similar efficacies also in both Western Africa as well as East Africa, which are countries with different transmission, by the way. But we're also working on a new generation of vaccines. The example is, of course, RH5, which is a blood stage vaccine, which has also shown a significant potential to protect against malaria. But we're also working on other forms of vaccines, like a whole sporozoite vaccines. But, leave aside all these sort of technical names and everything, what is important is that with all these tools, the question is, how do we really put them together? And moving forward, we are talking about a multi-stage vaccine. So if you have vaccines that can act at a different point, then it can really help. If you combine them, you can get an even bigger impact. And therefore, imagine combining R21 or RTSS with a blood stage vaccine, with a transmission-blocking vaccine. You can completely block the cycle of malaria and have a much bigger impact. And therefore, then we can start to realize the elimination and eradication using the vaccine. Because with the tools we have now, we cannot eliminate, but we have to really put more tools to be able to achieve that goal of elimination using a vaccine. But we're developing other platform. I don't want to really spend more time on this. The point here, in Africa, we are at the forefront of developing platform that can help us study the vaccine. We are not only sort of testing the vaccine, but we are preparing to be able to, discover new vaccines in the future. Okay. So finally, I want to go back to my first point. We need improving the health systems, and I bolded it there. And then we cannot solve this problem only by a vaccine. You can have a good vaccine, but if you have a poor health system, you go back to zero. So I wanted to make that point. So I think I'll stop there for the sake of time, and then we can discuss further. Exactly. Yes. Thank you very much. Thank you.
Thank you very much.
Yeah.
Thank you very much, Ali. I'm an old newspaper man, so I will give the highlights of why this is so exciting. 600,000 people die in Africa every year from malaria. Another 200 million plus are sickened by it. Solving this problem is probably the most revolutionary development in our lifetimes. This is not building apps. This is actually preventing people from dying and preventing them from being sick. It's been estimated that eliminating malaria or significantly reducing it creates automatically about 2% of GDP growth for the entire continent. This is not a small thing. So do not undersell your work, my friend Ali. This is what is so exciting for me, why I wanted you guys to come and speak here, because what we do at Africa in the World is to showcase the things that have the potential to dramatically improve the life of our continent. So, Dr. Adrian Hill.
Thank you. Wonderful. Let's go through this very quickly, because you've heard most of this from Ali. You've just heard the numbers again. I mean, it just really bears thinking about. 600,000 deaths in a year of young children. Think of all that potential. Think of the loss. Think of the grief. Think of the waste of human life. And we've been struggling with malaria since we've been human, because it's been killing people that time. And just remember the fuss we made about COVID, how much money we poured into COVID right around the world. Well, of course, there were more deaths from malaria in 2020, in 2021, and in 2022 from malaria than from COVID in Africa, right? So this is a big African problem, and we're getting close to solving it. You've heard very nicely from Ali, I've just put them on one slide, what's been used until now. Bed nets, insecticide, spraying indoors with those insecticides, and giving children drugs, not just to treat their malaria, but to prevent them getting malaria. A huge logistic operation, not really sustainable in the long term, but the reason one of those lines is in bold on this slide, $5 billion is what we spent last year on controlling malaria. And that's not eliminating malaria, it's definitely not eradicating malaria. That's what it's costing every year. You have better things to do with $5 billion than to spend it on controlling malaria. So the punchline of this talk, and we'll get there soon, is what Ali concluded as well, that we don't need to control malaria long term, we need to eliminate and then eradicate malaria. And the good news this year, and I've been saying this a long time, nobody's believed me, I think we can eradicate malaria, particularly with new vaccines. And that is super important. So if you remember one thing from today's session, it's we're not into controlling it anymore. Well, we are, but we're doing that for a reason, to get to elimination and eradication. So your grandchildren will say, what was that malaria stuff they used to have? That's where we want to be. And I think it's possible. Because not only do we have those tools on the top of the slide to come, vaccines, and vaccines have come literally in the last few months. There wasn't a deployed vaccine in Africa last year. There are 2 this year. There are going to be 2 more fairly soon, I believe. Monoclonal antibodies, widely used in medicine for all sorts of applications, from making sure that you stay thin to making sure that you stay alive. Some of you understand. And genetically modified mosquitoes. Can we do that? Complicated, maybe. Just to point out, this is not a new area of research. People have been trying a while. These 2 Algerian Frenchmen were working in Algiers in 1910 when they published this paper. So malaria is hard, is the reason I'm showing you that slide. It's not that nobody has tried. And if you read the bottom of that slide, 145 different malaria vaccines have gone into clinical trials, not into mice, not into research, into human beings, and you haven't heard of the vast majority of them because they totally failed. It's tough. We, until this year, had never had a vaccine against a parasitic disease of humans. None. Okay? Not for want of trying. Why are parasites more difficult? Well, they're a hell of a lot bigger, right? If you had a virus the size of a football, a parasite would be the size of this district, right? Thousands of times bigger. So just to really ram that point home, this is actually out of the Financial Times. Some of you recognize the color. This is how long it's taken to make vaccines, right? Bottom right-hand corner, the good news, COVID-19, months, not years. Top left-hand corner, malaria, starting in 1880 when the parasite was identified to 2023, really, 24. Very difficult vaccine. Just locally, where I work in Oxford at the Jenner Institute, we've been doing this a while. 1993, we started vaccinating mice. My big bugbear is there aren't enough places to do preclinical research on vaccines in Africa. That needs to be sorted out. Africa is not just for clinical trials, as many northern funders think it is. It's for inventing vaccines. More needs to be done in that area. I won't take you through this, except the highlighted ones are what we're going to focus on. R21, which you've heard about already, which is the best malaria vaccine we have. And the phase 3 data came in last year, and WHO pre-qualified it. So again, on the complaints section, malaria complexity, there are 5,000 genes. There are about a dozen in the SARS COVID virus, okay? Scholars argue about which is the best. Difficult choice. Different stages of the life cycle. You've seen that cartoon already. You'll see it again. Which stage do you go for? We go for the sporozoite. I'll come back to that. And then the damn thing changes, right? Antigenic variation. They swap genes around to evade the immune system. That's what happened during the last 30 million years when we had malaria infecting our hominoid ancestors. The parasite became super clever. It's genetically variable, like many viruses, and the parasite has been evolving to live happily in us. Well, the parasite's happy, we're not so happy. And then the punchline, the worst problem, is that we're pretty good at making vaccines that deal with some viruses. COVID was relatively easy. You need about 10, maybe 20 micrograms per mil, okay? Think of the numbers. 20 micrograms per mil. That's the concentration of antibodies floating around in your bloodstream, ready to hit the virus and take it out. You do that in malaria and get that concentration, nothing happens. Nothing works. The record in malaria now, on a blood stage vaccine that Ali is working on, is 800 micrograms. So it's more than a log, tenfold higher, to get something to work in malaria. And that's why 140 of those 142, or whatever it is, vaccines failed, because we couldn't get a strong enough immune response, because this was unprecedentedly, technically challenging and difficult. And malaria has led the vaccinology field in many ways in introducing new technologies and comparing them. So, take a deep breath. This is the life cycle of the malaria parasite. Very briefly, going from the bite on the top left-hand corner, injecting those sporozoites, and that's where our vaccines now target. We try to clear those before they get into the liver. If they get into the liver, you're into T-cell vaccines. Then the blood stage, where all the trouble happens. You die from blood stage malaria, not from the sporozoites, not from the transmission stages. And then another mosquito inevitably comes along, takes a blood meal from you. Different stages of the parasite life cycle, they've changed again. So different vaccines are needed for each of those 3 stages. The sporozoites, the blood stage, and the transmission stages. Which is going to be the best? For 50 years, we've argued. As academics, we now know that sporozoites have been the easiest to make. We have those licensed. But we need the other stages as well. Ali mentioned RTSS. Great work by GSK. Way back in 1984, they made the RTSS malaria vaccine. It started being rolled out in January of this year. Do ask the obvious question. Why did it take so long? Shall I just suggest it probably wasn't the most commercially valuable vaccine for a major pharma company to whisper it gently, to develop, but they hung in there, and the vaccine is licensed. And we learned a lot, we being the research group that made R21 collaboratively, and we improved on it. And there's a difference that you've seen in a cartoon already. Let me just emphasize that. On the far side, RTSS, you've got that orangey bit, right? And you've got the blue bits. The blue bits are actually hepatitis B. You've had that vaccine, very likely. We use that as a scaffold to present the malaria antigens on the surface of it. That's super important because if you put your antigen on a small nanoparticle, that means it's nanometers in diameter, far too small to see down a microscope, you get a stronger immune response. You get hundreds of micrograms per mil, not tens of micrograms. And that has made all the difference for both of these vaccines. So it's not chance that our only 2 malaria vaccines that worked are these nanoparticles, tens of nanometers in diameter. RTSS, back in the 1980s, couldn't get the surface covered with malaria. So those orange bits are the sporozoite antigen called the circumsporozoite protein. In 2011, a very young graduate student in our lab managed to make R21. It wasn't a work of genius. We were lucky that by then, yeast biology had advanced to allow us to use a different yeast. The yeast is the machinery we make the antigen in, and to express a particle that's now covered in malaria. And that has made a big difference. That's why, as I'll show you in a minute, R21 produces a stronger immune response, a better affinity antibody response, and better efficacy than RTSS. So it's not rocket science, it's not surprising that R21 is better than RTSS, and the immune response lasts longer as well, provided you put in a thing called an adjuvant. The vaccinologist's dirty little secret. We add in stuff to the vaccine to make the immune response stronger, and it works better. Like Ali, we do challenge trials. We invite volunteers to pop their arm on this tiny little espresso coffee cup. Because inside, there are these friends, Anopheles mosquitoes, that are actually infectious. And we have vaccinated and challenged hundreds of people, young, smart people rowing that morning come in for a quick bite, and 10 days later, they complain because we tell them they have malaria, and they say, I can't have malaria, I'm feeling fine. We say, we know. We do PCR, a very sensitive test to detect the malaria. The vaccine failed. A lot of our trials failed. Finally, R21 came along, and it was very different. This is slightly complicated. You've got 3 lines on there. Infectivity controls are the number of controls who didn't get vaccinated who stay malaria-free. And you can see in 21 days, everybody's got malaria. They got no vaccine, okay? RTSS is there in blue, over 50%. You get about 55% efficacy with RTSS. And in our first trial with R21 back in 2017, I remember where I was getting the results in actually Uganda, in the UVRI, and it was amazing. We were getting nearly 80% efficacy. Exciting. Then we got into bed with these guys. Incredibly important if you're going to distribute a malaria vaccine. They produced 3 billion doses of our COVID vaccine during the pandemic. They're working hard as we speak to produce more and more R21 and even the blood stage vaccines for malaria. They are literally the world's largest vaccine manufacturer. That's not in California, that's not in North America, it's in Pune in India. Right? The biggest supplier of vaccines to Africa at a very, very sensible price. I won't go through this in detail. We've done basically 4 trials. The challenge trial with those mosquito bites, VAC72. 73, a safety trial over in Kenya, in the coast, in Kilifi. VAC76, a crucial trial done by Halido Tinto and his amazing team in Burkina Faso. Why Burkina Faso? Because it has a horrendous amount of malaria during the so-called malaria season that Ali talked about. And then, crucially, for regulatory approval, a 4-country, 4,800 child trial that is still running. We have the data from the first 2 years. We're going to carry on following for at least 2 more years to ensure, not efficacy, we've measured that, it's pretty good, I'll show you in a minute, to measure safety. You don't want to have some horrible side effect turn up 5 years later. So quickly, here's Burkina Faso, Nenoro there in the middle, not far from Ouagadougou. Very simple design, just 150 children in each group. And because the transmission is so high, you get results like this. The red line on the top is the control group getting malaria, and the two other groups are different concentrations of the vaccine. So that was really exciting. 77% efficacy, unheard of in malaria before. Better than RTSS, we like to show the comparison, 44 against 77%. And even better, if you follow it out for years, the technical problem is, I told you need really high antibody levels. They go down over time. So what happens? Will the vaccine run out after a month, or after a year, after 5 years? Well, we've got data on 4 years, I can show you. And yes, the 77% has fallen to 64%. But it's not bad, particularly if you remember the age you are most likely to die of malaria in Africa is 1 year of age. As a young infant, you get protected by your maternal immunity and by a different hemoglobin in young infants. 1 year of age, you've got no immunity. You haven't lived long enough. It gradually builds up over time. So by the time you're an adult, unless you get pregnant, you're not likely to die of malaria. So that crucial first few years of life is when we want to protect children, and you will knock down that 600,000 deaths to maybe 100,000 if you just work in that age group. So we know a lot about this. I won't go into the details. The antibody levels do come down, but the antibodies improve. They become more avid. They stick better to the parasite, and they create better efficacy. So the critical test was VAC78. By the way, we're on to 99 at the moment. We've nearly done 100 malaria trials just for vaccines from Oxford. 4 countries here. You can see Ali on there, the Ifakara, fantastic partners, not just at the Serum Institute doing all the manufacturing, London School of Hygiene, their epidemiology is world-class, and Novavax providing the adjuvant. Here are the trial sites. Trial sites in... I wanted to make a splash. Good. In East Africa and in West Africa, these are really experienced trial sites. We had the pick of the bunch, and they've been fantastic. And we extended the age range from infancy up to 3 years of age, enrolling children to check we could vaccinate older children. And here's the punchline in yellow. We divided those 4 sites into those very seasonal, where there's mainly malaria in 3 or 4 months of the year, or all year round. And the efficacy is a little bit different, but really nothing to write home about. 79% versus 75%. And in similar sites, in similar trials, RTSS down there at the bottom was about 55%. So these are both useful vaccines. It's just going to be easier to really deal with malaria when you're close to 80% rather than close to 55%. Does it wane over time? A little bit. That line is sloping downwards, but it's not bad. And most importantly, why did we do 5,000 children when we could show that the vaccine worked in 150? It's because the regulators need to see safety data in thousands before they say, go and roll it out to hundreds of thousands or millions of kids. And the safety data has been happily unremarkable. So I've shown you that already. Can we actually deploy this vaccine? I pause deliberately. It's not trivial. We are distributing vaccine to some of the poorest regions of some of the poorest countries in the world where there is most malaria. Is there a system? And people in England ask me this. They say, you can't distribute vaccines in Africa. I remind them that more vaccines are given to young children in West Africa, for example, and other parts of Africa, than in somewhere like North London, where people have some concerns about some vaccines, usually ill-founded. So vaccination rates are higher in African children than in London children. Just remember that. And actually, African children need more vaccines because there are more pathogens around. But it can be done. Remember, childhood mortality in Africa fell from 2000 to 2015 by 50%. Half the children were saved. Why? Because in 2000, only rich countries were getting vaccines. By 2015, large-scale Asian manufacturers came in, made the stuff for cents, and suddenly nearly all African children were vaccinated with up to 11 vaccines. We need a 12th one called a malaria vaccine. So can we do that? The infrastructure is there. The price is okay. I think it could come down a bit more, but it's $3.8 per dose. RTSS is 3 times that, almost. It's very thermostable. It's not going to go off very quickly. The supply at the moment is 200 million doses. It could be 1 billion doses if there's somebody to buy the vaccine and distribute it. So I don't think that's going to be limiting. And programmatic deployment started in Côte d'Ivoire for no particular reason. They were quick off the mark a couple of months ago. These are the countries that are getting vaccine this year. Remember, nobody got vaccine last year, no country. So about half for RTSS and a half for R21. That's a huge achievement, getting that far. And even better, I was going to say we have an African manufacturer. It's not quite there yet. We want this vaccine to be made not just in India, but also in Africa. Here's DEC Vaccines, a startup in Accra, Ghana. The president was pleased. He showed up for the opening ceremony. These are the serum guys there. And there are other possible sites in Africa, as Ali mentioned, to make this vaccine regionally rather than just in Asia. Here's the key day, the policy recommendation from WHO in October of last year. UNICEF came up with them, Gavi, the Global Alliance of Vaccines and Immunization, came up with the money for UNICEF to distribute. So on our second last slide, next steps. Are we finished? Some people say, Adrian, what are you going to do now? You've got a malaria vaccine. We're not finished. We need a vaccine for women. Trials in pregnant women are starting in the coming days to weeks. But ultimately, I said at the start, we want to eliminate and eradicate this disease. We will need more than R21. We'll need a blood stage vaccine, RH5. Ali is working on it in Tanzania at the moment, made by my colleague in Oxford, Simon Draper. We'll need a transmission-blocking vaccine. One of the best comes from the NIH in America. Put those 3 together in the same vial with the same adjuvant, you're probably going to increase the price 50%. Not threefold, and you have a vaccine that I think will eradicate malaria. So you need all these things for impact. What I think we can do is at the bottom there, a 90% reduction in deaths by 2030. That's big. 500,000 going down to 1/20th of that, 1/10th of that. And elimination altogether, or maybe eradication by 2040. That is looking technically feasible. It won't be vaccines only. We'll carry on using spraying, using bed nets, but I think for the first time, it really is plausible that we will get there. Here's what I call the ultimate malaria vaccine, and it will be the ultimate one, because there'll be no need to make another one if you've eradicated malaria, okay? To enable malaria elimination and ultimate eradication, maybe in 10 years' time, 3 components. We have 1 licensed, we have the other 2 in clinical trials in Africa. They're coming along, and things are getting faster. But my last slide, I'm afraid, is about money. Can we afford to do this? My message is very simple. You can't afford not to do this. The cost of malaria, not in terms of childhood deaths or pregnant ladies' deaths, but in terms of loss of economic development, mandates this as a no-brainer. So just look at the numbers. This is just one analysis done by Malaria No More. That if you could eliminate malaria in the next 5 or 10 years, or even in the next 20 years, economic growth in Africa would go up not by millions or hundreds of millions. Their estimate is 16 billion average annually. That's in 1 year. GDP, okay, it's 2,000 billion in total in the entire continent. 16 billion is going to be kind of useful. It doesn't cost you 16 billion to do those trials. It costs you a few million. So this has to be done. The economic argument is as strong as the global health argument to allow development, to allow progress, and as a great example of leading research in Africa. So in conclusion, thanks to all the amazing PIs who actually did the work in these trials, including Ali, to the team at the Jenner Institute, many people there I won't go and read through, but it takes a small army to get these trials done, including people at the Serum Institute of India, are extraordinary manufacturers who can manufacture at a scale that pretty well nobody else can, and that's the entire list. Thanks for your attention.
Thank you. We actually tried to bring the people at the Serum Institute of India to come to Africa and the world this year, because that leads to the next natural question for us, that if you have a vaccine that is now at 95% efficacy.
One vaccine is 75, but if you add in the other bits, it should be in the
It should be close to that, right?
Yep, sure.
What's stopping us from getting it into the arms of children who need it?
So there are challenges. Distribution. You've got to reach every corner of every country if you're going to eradicate malaria. The mosquitoes fly, to state the obvious. They'll move it around. So you need a campaign. If you just do it in dribs and drabs in different parts of the continent, you'll have what you heard about in the 1950s in Nigeria, the parasite coming back because the mosquitoes come back. So you need to identify areas that are defined and try and eliminate there and keep it out. Whether that means screening at airports or whatever at ports, yes, we need to do that. So I'm not suggesting that eradicating malaria is going to be easy. It's going to be expensive. It's going to cost billions, not tens of billions, I think, but billions. But you're getting 16 billion back in economic growth every year is the key argument. So yes, this is a huge logistic effort. And believe you me, it's going to be much easier in some places than other places. And a very simple way to remember that is malaria is going to disappear from the outside in. Good news for Bagamoyo, right? Good news for the Gambia. DRC, going to take a little bit longer, guys, okay? But that's simply to do with the ecology of transmission and of the mosquitoes. So I think you will end out inevitably working from the outside in. And if in 2040 malaria is gone everywhere except, gosh, I have to pick a country, DRC again, we'll have made a lot of progress, okay?
So,
not easy.
Ali, what's your own view on that?
Yes.
Because you're actually dealing with the field, right?
Exactly.
At Bagamoyo.
Yes, so I think, I mean, just to add from what Adrian said, I think it also needs to, you know, it needs a stronger political will on the part of African countries as well. I think I come from a country that...
Have you seen any signs of that yet?
I think not enough. I need to see more. And I'm speaking from, you know, I come from Tanzania, and we've been doing all this great work, and I'm not very happy, for instance, that we haven't yet made our decision to which vaccine we're going to roll out. And if you look at the RTSS vaccine that has been deployed, we contributed the largest group of children in those trials, in the phase 3 trial, which was very critical. But the country has not made a decision. So I think I need to see more, obviously. And I think we need to do more advocacy, and we are trying to do that. We're trying to engage with the government and tell them, you know, we have the tools that we can use now to save the lives. And as Adrian say, if you can reduce the burden of malaria, you are on your way towards, you know, elimination and eventual eradication of malaria globally. So I think we need more sort of political will, and sort of countries have to invest and take action. So and I think I need to see that more, and we are doing a lot to advocate for that.
Okay, so let's back up a little bit. We have the vaccine. We have the facility in India that could manufacture it at scale, but they haven't got the order from Gavi or WHO. What is stopping that from happening? If you have a vaccine, but it's not being manufactured at scale, even though you have the capacity to do so, where is the blockage there?
Okay, from the manufacturer's perspective, they'll say, we'll manufacture what you order. We haven't had the orders, right? So the challenge is to see how well you can distribute a vaccine in all of the countries of sub-Saharan Africa at time points, and this is the wrinkle, that we don't normally vaccinate children at. We vaccinate children at 6, 10, and 14 weeks and at 9 months. Malaria is special. It gets 5, 6, and 7 months. And one of the things our lab should be working on and is working on is reducing the number of doses and seeing if you can give it at the same time as other childhood vaccines. And if we can do that, it makes the whole operation massively easier. But that's not going to change in a year because you need to do the trials to show you can use different time points. So it's still possible. The money should be in the system. This is a pretty inexpensive vaccine at under $4 a dose. The distribution costs add to that. But the impact, if you get a health economist in and do the numbers, is really major. This is very cost effective. Every modeler who's analyzed that will agree. So more money needs to come in more quickly. The answer from Geneva and the Centers of Global Health Power will be, look, it just takes time. It took 6 months from licensure to getting, actually it took 8 months, to getting the first doses rolled out. You have to train people. Training a whole new team that will do malaria as well as the other vaccination time points takes time, but it's doable.
And I also wanted to add a little bit on the fact that African countries have also to really invest in this. I mean, I had one slide. If I had time, I would have shown it. If you look at the investment that countries have been made on malaria control, it's only 30%. 70% has been coming from outside, and I think this has a significant impact in terms of how efficiently we can really implement these programs. And you find African countries with very good strategic plans to control malaria, but they're relying heavily on a foreign sort of aid to implement those. And these are some of the countries that I think they could spend a little bit more, and therefore that comes again with the political will and our choices we make to invest where we would have significant impact in terms of the economy. So I think there also needs to be that. And the gap has been, of course, countries have been increasingly investing, but I think it has to happen at a much faster rate as we move forward.
All right, thank you very much. We'll bring the audience into the conversation. We have lots of scientists, economists, bankers, oligarchs in the room. We even have a couple of oligarch friends that could probably fund the entire vaccine requirement that faces a lot of these countries. So interested in whether you have any questions for our panelists, so you can claim before they win the Nobel Prize next year that you met them first. So anybody has a comment or a question for our scientists? Yes.
Thank you. So I want to address the question to Ali. My name is Nonkuru Legonyembezi from the Standard Bank Group. You spoke about political will in really mobilizing the funding, public funding that you need to move things forward. Now, what we have seen in our continent, sadly, is there's more political will to purchase presidential jets than perhaps eradicating malaria. So if I share the experience of the HIV/AIDS in South Africa, we had an almighty fight to get the antiretrovirals out. But that fight was won because we had a very active NGO community that would not take no for an answer. In neither one of your talks have you spoken about the role of the civic society section in actually advocating for this, because frankly, I think you as scientists and doctors just can't do what they do. So to what degree are other stakeholders coming to the party to do what they do best to get us to move forward?
Thank you very much. I think that's a very relevant issue. And I think I must admit, for sort of malaria community at large, we are just beginning now to really make sure that we work very closely with this civil organization and community-based organization and the community at large. And if you look at sort of one of the sort of supporting element I've shown in that technical global technical strategy, actually calls for engagement of the community and making sure that they are part of this. And I think we just had our IHI, normally our institution, hold annually a malaria forum that sort of calls together different stakeholders, from the public health specialists to politicians and the community and civil organization. So this is our attempt to try to bring them in so that we are together in this. And I think there's been a disjoint in terms of communicating this, and I think if we are able to do that job very well, I'm sure that they will have a significant impact in terms of really speaking out and advocating for this. So we are taking up the challenge. Definitely there's more which needs to be done, but I think that's the way forward, actually, bringing together, bringing into this effort civil organization and the community at large.
Anyone else? Yes, Roger.
So so Roger Dickinson. It's a follow-up on that. I mean, I was just thinking the reason, and please don't take offense, the reason COVID vaccine was pushed through was because old white people were dying in Italy, and malaria is not pushed through because it's young African kids and women. And maybe it's a question to you, Delia. I mean, how do we actually change that? Because it's not about advocacy. It's actually about what's top of mind for the world, right? I mean, we were getting daily stats of who was dying from COVID in 2020. I mean, 600,000 people, kids and young people dying. It's the first time I've heard that stat actually mentioned.
I'll redirect that question to Dr. Hill, who alluded to the fact that, he developed COVID vaccine and he's helped develop the malaria vaccine. So perhaps you could tell us where the disparity comes from. Do not direct your questions at me, by the way.
So, your point is absolutely well taken. The way I like to present it is that when we were making COVID vaccines very fast in early 2020, there was as much money going into COVID vaccine development, and COVID hadn't been heard of 2 months earlier, right? Every day as was going into malaria vaccines in an entire year. So we were 365-fold underfunded. About $70 million has gone into malaria vaccines a year for the last 20, 30 years. Billions went into COVID vaccines. And of course, the manufacturers got their money back and made big profits in Pfizer and elsewhere. So how do you deal with that inequity is a much longer answer. Awareness is crucial. Look, I don't like a look on the downside. A couple of upsides to malaria, and that was the question asked compared to HIV. We have a system for paying for the vaccines. So you don't have to worry too much whether it's $2, $4, or $6. Gavi, the Global Alliance for Vaccine Immunization, paid for largely by the taxpayers of better-off countries by the vaccine. They will contribute a bit to distribution costs and deployment, but mainly that's a government responsibility. So the key question in Africa is, can the government pay for distribution of an 11th vaccine? 10 are being distributed already. Yes, it's a different time point. It's a bit more expensive than other vaccines, but believe me, vaccine prices don't go up. They come down because other manufacturers come in and distribute. So yes, more awareness is always important. HIV has done an amazing job, congratulations, in getting deaths down, mainly, though, through investment by big companies in developed countries to deal with people with HIV in developed countries. We don't have that same investment in malaria. But we now are getting tools that are really cost-effective, and let's see how far we get with them. But it will need advocacy primarily from Africa, not from a guy like me sitting in a university in England, to get this to happen.
Thank you. Biola.
Thank you. Thank you for your presentation. My name is Biola Alabi. I work at the intersection of media and technology from the investment side. There's a little bit, there's sort of a little bit of addressing it already, but actually, Delia, I think this is where you come in. I know you don't want us to, but I think that one of the things that is challenging, and hearing the numbers today and hearing the excitement today that we're on the brink, actually you're not hearing that from a storytelling perspective. You're not hearing that from a media perspective. There seems to be a general apathy and acceptance that we have to live with malaria. And so for me, as someone that understands the power of storytelling, my question to you, Delia, is how do we activate and actually switch this apathy to advocacy from a media perspective, from a storytelling perspective, and from a general engagement perspective? Thank you.
Thank you very much. What's the next question? I actually don't have any original idea about that, other than that the various tools of storytelling that have proved effective over time and in many circumstances typically would involve an individual or group around whom you can anchor the story, right? So if we have dynamic leaders in science who are doing stuff and have the capacity to communicate through the power of storytelling the importance of some of these breakthroughs, that will be one entry level. Or it might simply be an activist of public health in Dar es Salaam or in Bamako or somewhere, who, through sheer force of personality or their backstory, are able to become an emblem of that particular challenge. It's not enough to just like write a story in a newspaper or put it on BBC. That's not how mass campaigns prove effective. And since I am actually not a member of the panel, I'll just stop there to say there are other ways we can kind of deal with this, but it's not going to be by simply writing that we had Dr. Hill and Dr. Olotu in Stellenbosch last week and they were talking about malaria. Nobody is going to read the story. The story needs advocates whose stories become an emblem of the issue. And people, through them, gain a particular understanding and are impelled to act in effect. So that it's a long story, it's a different subject, but I understand what you're saying, and you understand this better than me anyway. So we have to find a way to make superstars out of people like this so that people can respond in different ways to how to solve this problem and create the political momentum that can make our leaders buy fewer planes and spend more money at the Serum Institute of India.
Can I just add on that? We've been there and made the movie, Ali is the Star. It's a documentary called The Battle to Beat Malaria. It's up for an Emmy Award in the States this year. And it's available. It's been shown on PBS, it's been on the BBC, it's going to be on Arte, it's going to get here sooner rather than later, I hope. So it's worth a look, because it captures the message really well.
Thank you. Yes? Yes, John.
Good morning, thank you. John Dacey from the States. Two questions, one economic, one medical. On the economic, the data that you presented in terms of should eradication take place in the increase in GDP, does that include the cost avoidance of care for those who have that? Or would that be on top of it?
No, it's got everything in there. This is an advocacy organization. It's one of the good ones, Malaria No More, trying to show the potential benefits. And they look about right to me.
Great. The other one, have you found anything common physiologically for those individuals for the vaccine does not take?
Yeah. Pretty well everyone makes an immune response, but it varies in magnitude between different individuals. And sure, there are going to be all sorts of things, including host genetics that you allude to, impacting on that. Just to give you a scale, we're not increasing the natural immune response from natural infection tenfold. This is going up 10,000-fold. So it's absolutely huge. It's hard to keep it up there, as I mentioned, but it lasts years, and that's really good news.
Thank you.
Okay. Yes, Jacob. I think someone is bringing you. Yeah. You have a microphone behind you.
Jacob Marie, Standard Bank. The Gates Foundation has been so involved in malaria for such a long time, and we haven't heard their name mentioned. I just wondered if they have an important role to play in this.
I take that. No, go ahead.
Thanks, Ali. So let's go back to 2000 when Bill was setting up with Melinda the Gates Foundation. His #1 project was malaria. And within malaria, it was making a vaccine. That has all changed. And maybe it's just exhaustion with the promises and false hopes and so on. But these guys are very technically clued up. And yes, they're funding us, for example, to produce that slow-release formulation that might get 3 doses down to, ideally, 1 dose. But I get a sense they've lost heart a little bit, and they're not still in it. Yes, they are in the vaccine space for malaria, but they're not investing as heavily as, say, something like EDCTP, Alphabet Soup you probably don't know, an amazing organization that partners European Union countries with African countries. They've been the main funder of R21, to be blunt. It wouldn't be here, but for them. So the answer is partnership. Absolutely, it's more funding, and people have to stay in it for the long game if you're going to do diseases like HIV and malaria. So gates are still there, but not as directly involved in malaria vaccines as I would like.
Okay, we can take a couple more questions. Amma.
Is there no way to eradicating the malaria mosquito?
Okay, you do not have entomologists on stage. The idea is not new. The idea is a good one. You genetically modify the mosquitoes. The problem is not making those. They exist in insectaries. The problem is getting them robust enough to replace all other mosquitoes. It's a little bit scary to start with, but the idea is definitely there. It's kind of working for dengue, different mosquito, of course. So yeah, that's still on the cards, but mosquitoes breed really fast, and you've got to get the right ones to breed, and that's not trivial. So it's one of the potential tools coming along. So are monoclonal antibodies that will treat the malaria, but they're just super expensive. For it's not going to be $3, it's going to be $300, something like that. So people are still. Hopefully, we won't need to genetically modify the mosquitoes. That's going to take time. So but you're right in principle.
Just to add on that, I think also, just to follow up on Adrian's, so yes, it is one of the tools, and maybe to give an example of our institution, Ifakara, we have generated the first genetically modified mosquito in Africa. So most of the countries, of course, they will sort of ship these mosquitoes from outside, but we are doing it internally in Africa. And the idea, as Adrian said, it is a bit scary for us to sort of release these mosquitoes. So we are working very closely with the community, and we are going very careful so that we win the trust of the community. Community understand what we are doing. We are bringing on all the civil organizations, the community, so that once we release it, then everybody's on board. So I think that is also one of the tools, and I think we are pursuing that as sort of from within Africa.
Thank you. Yes.
University of Pretoria public health physician. So it's a wonderful day that we have a vaccine that's effective, and congratulations. But it reminds me of this meeting at the World Bank in DC, where ministers of health and ministers of finance got together. The World Bank convened them. And the ministers of health were asked to set their agenda for health priorities in Africa. And they brought all the data, cost effectiveness, return on investment, the clinical trials, etc. And the ministers of finance looked at them and they said, oh, this is all lovely. Just tell us you can get it done, right? And the feasibility of implementation is something we struggle with. And this, and particularly with this audience here, when we look at competencies outside of the researchers and doctors, what do we need to bring in? And as a public health physician, I can say this, very often doctors are logistically challenged, right? But distribution, logistics, administration, these are all competencies from the private sector, marketing, branding, behavior change. And we have excellent examples from HIV. So what is the platform that's going to quarterback or coordinate the response of multi-sectoral partners, bringing very different competencies so we can get maximum coverage as fast as possible?
I'll start. Yeah. You can continue. Look, we're not starting from nowhere. Today, bed nets are being distributed in essentially all African countries that have substantial malaria. They're impregnated with insecticides. There are drugs being given out in the more seasonal localities where you give 3 or 4 rounds of drug through the main malaria season, and that has had major impact. There's more rapid treatment, there are better treatments coming along, and those are being deployed. Okay, not absolutely perfectly, but they're making a difference, and you can measure the impact. This is just another tool that, you know, I would argue, and I'm a vaccine guy, that as a single intervention, R21 giving you 78% efficacy over a year is higher than any of the others individually, but it's not an individual game. You're using all these tools together. So the great thing about vaccines is, A, somebody else is paying for them, northern taxpayers, and secondly, we've shown that we can do it and halve childhood mortality in Africa from conventional childhood vaccines. Let's add to malaria to that, and yeah, it's going to be a little bit bumpy to start with, more doses than we would like, not the same immunization time points, but all of that will improve over time. So those ministers of health need to see the numbers. They're not vast on top of what's happening already, and they're definitely very cost effective. And economic growth, tell them, will go up.
So just to add as well, I mean, when I can speak specifically for the malaria vaccine, when it comes to deployment, I think there's already sort of data showing, because when RTSS was approved or recommended by WHO, we had this implementation program that sort of delivered the vaccine in a real-world setting to see whether this is something feasible to do. So the answer is absolutely yes. So there were 3 countries, Kenya, Ghana, and Malawi, which sort of went first and gave the vaccine. So I think it is possible to deploy it. As Adrian says, it's not a perfect system. Obviously, we have to work hard to ensure that the 4th dose, which is also one of the requirements, because this comes a little bit later in the year. So if you look at the numbers, so the coverage for the 1st, 2nd, and 3rd was pretty high, very similar to what to other sort of childhood immunization, but the 4th dose was a little bit lower, because then these kids have to be mobilized, you know, to come for that sort of 4th dose, which is usually outside the normal childhood immunization. So I think that is where we need to sort of engage with the community and be a little bit innovative. One approach is actually to use the community healthcare workers, which have been sort of the cornerstone of health, primary healthcare in Africa. So if we can bring them in. So I think the infrastructure is there. I just want to go back to what Adrian is saying. We have the infrastructure already. We have an EPI program of immunization, which has been instrumental in saving millions of lives. So as I say, we need to add this vaccine. Yes, there will be some additional cost, but at least we have somewhere to begin. So that is as far as the vaccine is involved. But when we talk about, you know, eliminating malaria, you're very right. We need to bring all these multi-sectorial sort of dimension into it. It's not only about biological, aspect of it, the social aspect of it. And, in the global technical strategy, this is one of the fundamental supporting elements, which is really necessary. So, universal health coverage, improving healthcare system, bringing these other sectors so that they can talk together. And in Yaoundé, in March 2024, the Ministry of Health of Africa came together and they said and agreed, again, we have this multi-sectorial approach. It's actually very critical. So I agree with you. We need that, and I think countries have to think about malaria not only within the Ministry of Health, but bring all these other ministries as we move forward. Thanks.
Thank you very much. That will be the last question. Here.
Thank you, Dile. The lady in front of me says I might not need the mic. She knows me well. It's a fascinating conversation, and given that I've been involved in, let's say, the global public health space from a private sector standpoint, not as a provider or a solver of problems, but more as a mobilizer of resources and hopefully an advocate. I'd like you to comment on something that I have said a number of times. If you think about pandemics, including malaria, the world mobilizes around the challenge with the fear, the concern as to this is a big deal, we've got to solve the problem. And the multi-sectoral approaches, the heavy investment in science research and the problem solving that is required is done with most continents in mind. But pandemic after pandemic, and malaria was considered a global pandemic beyond Africa 30 years ago. Tuberculosis, obviously we've gone through COVID more recently. What happens is that when the world solves the global problem, Africa is left carrying a disproportionate share of the disease, no longer a pandemic, simply because the rest of the world has solved it. So today, 90% of malaria deaths are in Africa, not because 30 years ago, 90% of malaria deaths were in Africa, simply because all the other countries that had malaria deaths, including the USA, by the way, have solved the problem. So malaria has been eradicated in some parts of the world. By the way, Africa just doesn't seem to be able to solve the problem. And so you then ask yourself, are we continuously going to be the last frontier of problem solving? And somebody says yes, very pained, and it boils down to one thing. If the continent is not better led and better governed, we will just keep, it's going to be health or it's going to be something else. So, the conversation has to continue. And I didn't raise my voice.
Thank you very much. Thank you very much. I have an old friend who passed away nearly 2 years ago, who used to tell me in our Fair Valley here in Banhook, Stellenbosch, politics trumps everything. And this remains true for every challenge that we possibly face. The places that are poorly governed have more problems, and the places that do a little bit better can solve some of the challenges that they have. So we have to keep going back to this question of governance of politics, which we opened with last night, and this shall continue. But that is also a good way of thanking our speakers, Dr. Ali Olotu, Dr. Adrian Hill. When you win the Nobel Prize, we're going to share the money.
Thank you very much. Thank you. Thank you very much. Thank
you. And a natural extension of this conversation is, as we solve one problem, as Egg you just referred to, there are other problems that we leave behind and quickly forget about them, even though they are with us. And to help us understand some of those ongoing challenges will be Dr. Tulio de Oliveira of Stellenbosch University, an epidemiologist, and a man that probably half the people in the room at least know from watching too much TV, Dr. Dr. Salim Abdul Karim, who I think you shuttled between University of Natal and these parts, in addition to your expertise being constantly in demand in various forums. I'm glad you're able to join us this morning to talk about those things that